Right. Hi, everyone. We're just waiting for everyone to be able to pop on. Thank you so much for joining us for today's webinar. My name is Diana Guevara, and I'm the Community Health Education Specialist for the Nourish Program and a graduate of the Dietetic Internship Program at the Michael and Susan Dell Center for Healthy Living, housed within the UT Health Houston School of Public Health. The Nourish program shows people how to grow, prepare, and promote food that encourages lifelong health and well-being through hands-on, evidence-based classes taught across our garden, kitchen, and community. So in the next slide, we'll see the Michael and Susan Dell Center for Healthy Living, who is hosting today's webinar. The center's vision is healthy children in a healthy world, with a mission to advance health and healthy living for children and families through early and impactful interventions. In the next slide, we'll thank the Michael and Susan Dell Center Foundation for providing funds to the center. And in our next slide, you can see information about our center's work and resources, which can be found online. So you can scan the QR code on your screen to access all of the health resources that the center provides. And the next slide, we'll see the Center for Healthy Living also leads the Texas Research to Policy Collaboration, Texas RPC project, which creates the legislative related resources described on this slide. So you can scan the QR code here to learn more here as well. And be sure to check out our upcoming webinars here at the Center for Healthy Living. In April, we have two related to substance use and nutrition. So we have Tucker's Law and Best Practices in Youth Substance Misuse Prevention, April 2nd, that's coming up, and then Best Practices in Youth Nutrition Education, April 16th. The slides and a recording of today's webinar will be archived on our website, and if you have any questions during the presentation, please enter them into your questions chat box for the Q&A at the end of the presentation, and I'll be sure to ask those. Okay, and then that's our website. So without further ado, I'm excited to introduce my co-presenter for today's topic, Dr. Jane Hamilton. So since 2018, Dr. Hamilton has been the principal investigator and project director for the Substance Abuse and Mental Health Services Administration funded UT Health Houston Homeless Outpatient Mental Health Expansion Services, UT Health Houston Homes program, which provides integrated behavioral health treatment to persons experiencing homelessness. In 2013, Hamilton received a PhD in Health Services Research from UT Health Houston School of Public Health and completed a postdoctoral research fellowship in mental health outcomes research at UT Health McGovern Medical School. So now here's Dr. Hamilton with her presentation on nutrition intervention among formerly chronically homeless adults in permanent supportive housing.
Thank you. So it's really good to be here today, and thank you, Diana. So I'm going to first cover our learning objectives for today's presentation. So our first learning objective is that we are hoping that participants will be able to demonstrate increased knowledge of the barriers to food insecurity, security in permanent supportive housing, to addressing it among people that are chronically homeless, which are people that have a history of homelessness of more than 1 year. We also want participants to be able to describe the training for community health workers to deliver nutrition-focused interventions in permanent supportive housing, how to identify best practice strategies to improve food security, social connectedness, and health outcomes for persons placed in permanent supportive housing with a history of chronic homelessness, and also to recognize how a human-centered design and methodology really improves resident engagement. So what is permanent supportive housing? Permanent supportive housing is an intervention that combines subsidized housing with flexible supportive services. This is really critical because the housing affordability issue is a main driver of homelessness. And so in this country, housing is considered affordable if people don't have to pay more than 30% of their income towards housing. So by providing subsidized housing as well as flexible supportive services, we're able to house people who have been chronically homeless, that defined as having both a disability and being homeless for more than a year. So permanent supportive housing for people with histories of chronic homelessness is the leading housing solution in the U.S. for among people experiencing homelessness. They are often diagnosed with physical, mental, emotional, or developmental disabilities, or more than one, and they do require ongoing services and support. So by having housing solutions that have low barriers to entry, so there's no programmatic preconditions such as sobriety requirements, completion of alcohol or drug treatment, or even expecting residents to agree to comply with a particular treatment regimen upon entry, we're able to house more people quicker and to really start delivering the right kinds of services. So it's been shown to effectively reduce homelessness and to promote housing stability, especially among people who encounter multiple barriers to housing. And it's been associated, so permanent supportive housing has been associated both with lower healthcare utilization and lower incarceration rates. However, there's still a need to link it to improved health outcomes. So we're going to talk a bit more about that today. So food insecurity is particularly problematic among people in permanent supportive housing. This is across the U.S. So what is food security? Well, food security has been defined as a household having access to adequate, nutritious, and safe to cook food. So we want the foods to be fresh, to be, there should be safe cooking practices, they should be easily accessible and healthy, but there's a lack of health equity. There's the lack of food security among people in permanent supportive housing is a health equity threat for formerly chronically homeless people, even after they transition into housing. So research in California that we found as part of delivering our UT Health Homes program found that 67% of permanent supportive housing residents at several permanent supportive housing programs in California were found to have low or very low food security, far exceeding the general population's prevalence of 22% for low-income adults. Also, what the food insecurity research is finding is that permanent supportive housing residents actually have higher rates of food insecurity compared to people who were still homeless. So we became curious about this and concerned because as part of our integrated behavioral health treatment program, we try to address all social determinants as well as the mental health needs. So we partnered with the permanent supportive housing program here to start looking at this issue. So the issue is, despite subsidized rent and permanent supportive housing, we're learning that these residents often struggle to meet other expenses, and including obtaining food. So what is the relationship between homelessness, housing, and health outcomes? Well, adults entering PSH are likely to have high disease burden and poor health outcomes. So they're coming out of homelessness, and homelessness has been shown to be a key driver of poor health outcomes, including a shorter life expectancy, higher incidence of acute and chronic health problems, higher inpatient utilization, more psychiatric hospital visits, more ER visits, as well as longer inpatient lengths of stay and higher healthcare costs. So it's really important, especially as public health professionals, as healthcare providers, we want to go upstream and address these social determinants, such as food insecurity, to improve health outcomes for this population. So food insecurity and health outcomes in permanent supportive housing. So many of us have studied this issue, and we've learned that a nutrient-poor diet among people experiencing food insecurity impedes the self-management of chronic illnesses, including heart disease, hypertension, diabetes, chronic kidney disease, and even it's been linked to depression. And higher levels of food insecurity and poor diet among PSH residents have really been posited to partially explain the lack of definitive health gains we're seeing for this population. So we hear that housing is healthcare, but what we're finding in the outcomes research is this isn't always the case, that we see the improved health outcomes. So there was a consensus study conducted by the National Academies of Sciences, Engineering, and Medicine, and they looked extensively at permanent supportive housing, and they evaluated the evidence for improving health outcomes among people experiencing chronic homelessness just through the housing intervention. And what they found is that it may be common and even the norm for people in supported housing to live with food insecurity. So we're not seeing housing people truly translating into improved health outcomes yet. You know, we see lower utilization, but we don't necessarily see the residents getting healthier. So we're trying to figure out what's driving that. And so this is the reference. If y'all would, this is a publication that's really informative if y'all want additional information. But based on what we began reading, we decided to seek out funding from Houston Methodist in Houston, Texas, to implement the pilot implementation of a nutrition-focused community health worker intervention. So Temenos is a 3-building permanent supportive housing program in Houston, Texas. At the time when we received funding from Houston Methodist, they had 140 residents. So Diana and I are going to talk a little bit about our project and some of our successes and some of the things that we still hope to accomplish with this population. So we have published our initial findings from our project in the International Journal of Environmental Research and Public Health. This is an open access publication if y'all would like to find out more information about our project and outcomes. But I want to talk a little bit about achieving health equity. So our pilot program was implemented from 2022 to 2023. We recruited and trained 3 community health workers to deliver the nutrition-focused educational empowerment intervention, as I said, to 140 residents in Midtown Houston. So when we initially began the project, we worked with Dr. Sharma and at the School of Public Health, and we identified the USDA Food Security Survey as a validated instrument that we used as the basis for developing a needs assessment. And we hired our full-time community health worker, Sarah Seinfeld, who I'm hoping is here today, and worked with Dr. Simmons, who is the Vice President of Health Equity at Bread of Life. And we went door to door at Temenos, screening residents for food insecurity, using this validated assessment, as well as asking additional needs assessment questions. We added vision questions. We worked, Calvin Wong, a medical student from McGovern Medical School, joined our project, and he developed some evidence-based vision questions. So we really developed a comprehensive assessment, went door to door, and learned that 64% of the residents were identified at baseline as having very low food security. So it's very similar to the rate found in California in their PSH program. So their rate was 67%. So we also found through the needs assessment that all 83 residents at least lack some necessary items for safe cooking and eating, but we wanted it to be each one of them to have a fully stocked kitchen. So they had some things, but we did find gaps. So that's another issue we started addressing. Our overarching goal was to reduce food insecurity and the nutritional deficiency by increasing access to healthy foods, improving nutritional literacy, improving safe and healthy cooking and eating practices, and building community and social connectedness through group activities. So this is a multi-level intervention. And around this time, we realized we needed to have a dietitian, a public health dietitian on the project. So we recruited Diana, and we came up with this human-centered design process. So we really wanted this to be a people-centered, resident-centered project, and we wanted there to be a lot of buy-in. We also wanted there to be a lot of sustainability because this is a one-year pilot project funded by Methodist. So these are this is our implementation timeline. So we focused very heavily on university-based training. So we had public health nutrition modules through Nourish that we made available online to the community health workers. We also partnered with the University of Minnesota's extension program for SNAP Ed training. They were very wonderful and created a web-based training that was tailored to the needs of our community health workers, so we could make sure that what we were doing once we started addressing gaps and connecting all the residents with SNAP, that they could make the best use of their SNAP benefits. And as I said, we hired Diana, we started weekly staff development meetings, and then Diana also coordinated a site visit with the UT School of Public Health university-based teaching garden to really, once we wanted to start implementing our community garden component, we wanted to make sure that the community health workers could provide the best assistance to residents. We also received additional funding from McGovern Medical School, and we developed an interprofessional social determinants of health course that we taught at McGovern Medical School, which was really wonderful because it culminated in a luncheon at Timonos with our participants and medical students and other providers. It was a very great way to bring everyone together and build more community. We also, during Q1, as I said, we did food security screening and needs assessment, and then we began apartment inspection. So we wanted to provide one-on-one health education and apartment inspections in the residents, single room occupancies, to really see what kind of food was in their apartments. Were they able to cook safely? Were they able to read nutrition labels? Did they understand what types of foods they should be buying? So, and then once we started providing the one-on-one support, we identified the need for healthy food linkage. So we really worked with our partner again, Dr. Simmons at Bread Alive. They run a food distribution that's citywide twice a month, but we wanted to make sure the permanent supportive housing residents were linked with the food distribution, and then also that they could get linked with other distribution programs. We started a Ask a Dietitian session. We provided the kitchenware linkage. We provided linkages to community resources. And then at the group level, we started pop-up grocery stores, cooking classes, nutrition education sessions, grocery store field trips. We eventually started the community garden. We created a resident cookbook, and then we had our graduation. So we'll go through these activities a little bit in more detail. Just to let you know, this is our logic model that y'all can reference later on if you want to access our publication. And then I wanted to discuss a little bit more community health worker training. So again, we worked with the University of Minnesota to provide the evidence-based SNAP-Ed curriculum training. Diana provided ongoing training. We worked with Nourish, and we provided the public health nutrition training modules, the teaching garden site visits, and ongoing supervision, as well as weekly project meetings that Dr. Sharma, Dr. Simmons, and I all attended, along with the community health workers and Diana, to really make sure that we were implementing the project correctly. And then also, as part of our human-centered design approach, we were regularly reading resident feedback and taking that into consideration. So how did we obtain resident feedback? So as part of the human-centered design process, systematic feedback was obtained from residents to tailor their nutrition education. And I'm gonna read through the questions, and Diana, if you want to talk a little bit more about this, it would be great, because what the community health workers did is they asked the residents to submit responses to nutrition-based questions on comment cards. Following each healthy cooking class, we were asking the residents to provide written feedback about their nutrition goals, what they liked the most, what new things did they learn, what suggestions did they have for improving, and even what dish would they like to learn to cook. So this is our human-centered design process, and I am just learning about this model and how to implement it, but I do feel like that it was very helpful to ensure that we brought in, again, that resident-centered approach. We really focused on listening, understanding, talking to the community health workers, talking to residents, obtaining feedback, trying to collaborate with the staff. And we found that to be very critical to work with the housing staff, to continually look at our objectives, and to adapt what we were hearing in order to create and deliver a more resident-centered approach. So again, we used this multi-level approach that was based on validated screening, and we actually conducted 228 pantry inspections for food insecurity and nutritional deficiency, and we provided 83 residents with needed pots, pans, cooking utensils, cups, dishes, flatware, and small appliances. Dr. Simmons, who works with the church, this is a faith-based program, St. John's United Methodist Church of Downtown. Dr. Simmons engaged the church members in fulfilling the wish list. So we regularly had people donating different items that were needed, and then the community health workers were just wonderful about distributing, making sure that all the residents got what they needed, and then working with them to use the things that they received through the wish list. And one particular thing that I think Diana really recognized the need for was two things, like the knife skills class, and then also how to use a meat thermometer. Did you want to talk a little bit about that?
Sure, yeah. So it was great having the CHWs there on site because they really made those connections and they were able to talk with the residents, go into their spaces and see what they were doing and maybe where the gaps were. So two kind of topics that emerged were one, of course, knife skills is just important for anyone, just for a safe cooking environment. And then two was food safety. The CHWs were, and speaking with them and watching them cook, they noticed that they were trying to cook chicken in the microwave, and they were their stovetops weren't quite as effective. So we really wanted to make sure that they were safe in that aspect. So we did a whole food safety course, or a little. It was actually a game. It was very fun, but we'll talk about that later. But yeah, those are the two topics that emerged.
And another thing that was really amazing that the community health workers picked up on was that all the mobility impairments among the residents. So in general, the homeless population is an aging population. The majority of people experiencing homelessness in the U.S. are over the age of 50. So many, and then also having histories of chronic homelessness, it meant that all the residents had at least some kind of a disability, whether it was a physical impairment, mental illness, but that what we found was that 72 of the residents had impairments that kept them from being able to go to the bi-weekly food distribution. So the community health workers organized a way to bring box items to the residents. So I think that was another concern that really helped our program to be successful, and it really mirrored the research results found in the California study. So this is another issue to be aware of, and this linkage to food pantries. So we also focused on disseminating flyers as well as accompanying residents to pick up food, and then assisting all residents with SNAP benefits, and then once they obtain SNAP benefits, signing up for Amazon Fresh if possible, because the permanent supportive housing units, as well as many permanent supportive housing units across the U.S. are in food deserts. So this was another issue that we wanted, another gap that we wanted to address, because there's no close by grocery store. So I'm going to turn it back over to Diana again, but she implemented 10 nutrition education sessions, and I met with the community health workers weekly. So did you want to talk? I'll go through all of these, and did you want to talk a little bit about this part?
Yes, so when I came onto the project, I met with the CHWs, the community health workers, and they already had a great understanding of the residents' attitudes, their kind of beliefs towards nutrition. So it was really helpful to have them there and having those connections. So from speaking with the CHWs, I realized that they were definitely, if you know about the stages of change, that our residents, most of them were in that pre-contemplation phase. They were not interested in learning about nutrition and really knowing adults in general. They don't love sitting in a classroom style education session. So I really wanted to meet them where they were. And in the permanent supportive housing at Temenos, they were already doing games. They were already doing kind of community activities together, and they really enjoyed them. Those are the things that drew the most residents out of their units and into the little community space. So what we did was develop just games that they were already familiar with. We did bingo, we did Jeopardy, we did all sorts of games. Price is Right, I can see there. But we made them nutrition focused. So it was a Price is Right, but we were comparing prices. So we were comparing canned beans versus dried beans, and it was just kind of raising that awareness of, oh, well, if you get dried beans, your dollars, your SNAP benefits can go a bit longer, a bit more if you're able to see those kind of get those cheaper items that are still perfectly healthy and wonderful. We also looked at kind of nutrition comparisons. So we did like the oats, the regular quick cook oats versus like the packets where they would have added sugar. We did an orange versus orange juice. So we added those nutrition components in there, but in a way that was a bit more approachable and more of a game activity. And the residents really loved that because not only did they learn a little bit, but they also got to really build that community with their co-residents. So there's a quote here. I enjoyed the nutrition sessions the most. I was homeless for 2 years and needed to be reminded of the basics again, like how to slice avocados and tomatoes. Practicing during the nutrition classes was helpful. So our residents, they've lived a long life. They know these things. We all know, what it takes to be healthy, but it really is just raising that awareness again because they are dealing with so much. And so that's a picture of us during one of our cooking classes. So again, we asked, the CHWs asked the residents to submit questions, things they were curious about, things they wanted to learn, and the bigger themes like the safety and things like that, we turned into full classes. And then the little topics we just included into our games. So another piece of feedback, yeah, they said there was a lot of enthusiasm around it, but they also learned things. They learned how to spell squash, turnips, collard greens, different vegetables, fruit juices. So they said it was a lot of fun as well. Loved the program, loved the games, and the program was very good. So they really just got to have fun, and instead of it being a strict like eat your vegetables kind of lecture style thing, it was just a fun and very approachable way to learn a little bit about nutrition and kind of just plant that seed of, maybe if we make some different food choices, maybe, you can feel better and feel healthier. So that's just a list of the different types of games we did. Again, we did a nutrition Jeopardy, food safety Jeopardy, Price is Right, My Plate Bingo, and they loved all of it. And then of course we had some prizes. So with the Amazon wish list, we were able to provide little cooking equipment and things like that as prizes. But everyone was a winner, and they all really, really enjoyed it. It was fun.
And
And then,
so, sorry, go ahead.
no, just our cooking classes. So that's kind of our bread and butter here at Nourish. We know that actually hands-on cooking is what's going to lead to a little bit more of that behavior change. So we taught some knife skills classes. We did a 10-minute chili with just canned items. So I really tried to make it as approachable as possible and use the ingredients that they're either getting from their food distribution or items that you can get easily from SNAP, or items that are shelf stable that you might get from pantries and whatnot. So, and then of course the kitchen equipment was very simple, just a knife, cutting board, and we used either burners or the microwave. So things that they would already have in their units.
And so, in conducting the follow-up interviews, I talked with a lot of the residents. And so one of them left this quote, all of it. He really appreciated all of it, especially the black bean soup. So that was I know the first cooking class before we brought Diane on, I went to and got food from the distribution, and I was like, what can I cook? So I cooked some black bean soup. And they liked it so much that I think you had ongoing training on how to make it, because it's something that can be very easily put together with items that they collect from the distributions, or as Diana said, that they can buy with their SNAP benefits. And so the resident told me, he's like, all of it, especially the black bean soup. I like to cook, to learn. I had forgotten a little. I learned a whole lot. I really did need it. I am now cooking Spanish rice and beans and making salad. So a really big part of our learning and the way we were able to adapt our program was this recognition, just as Diana said, that these are people who had at one point in their lives been self-sufficient, but many of them had fallen into chronic homelessness. And so there was some relearning that was needed. So being able to really provide that collaboration and respect, and to really learn, the patient-centered part, the human design, I think was the most critical piece, because really listening to them and seeing what they wanted to learn, how they wanted to lead, I think created a really high level of engagement. And so it was very successful. And as you can see, there are many of us out there cooking and cutting and slicing, and it was just a lot of engagement. As you can see, we used the equipment that was bought with the grant. So I think that's another piece to consider if the participants are interested in a similar type project, is to take a look at the environments and how the participants will need to cook their own meals and to buy similar equipment. So we did include that in the initial budget, the need to have a mock kitchen. And as you can see, these are demonstrations, and some of the residents are cooking their own food in the common areas. So it also created like a way to really engage the residents as leaders and to also build kind of a tiered volunteer system. And so that's, we use a lot of peer-based models. So we want to, as far as sustainability, we want to, as much as possible, just facilitate some of these interactions and these activities, but then turn it back over, since we know the funding will not go on forever. So another resident was really excited, reporting that they learned a lot about spices. And, so this resident wrote, learning about the spices in the class, it really brought it back to me how to cook. Once you get it, the taste buds help you create your own spice mix. Well, we really focus on spice mixes as well, because we're trying to teach the residents to eat less salt, but how do you, and often too, make things like canned beans taste better. So we really tried to focus on taste. And another resident reported, I did everything. I cut the onions, I used cold water, I prepped and cooked the chili. I learned to cook chili in a different way. I put chopped onions in the air fryer. So we also provided everyone with an air fryer in their rooms, because that is a safer way to cook. We were concerned about some of the residents being able to cook on the burners. And so there was just a lot of enthusiasm. And Diana worked with the residents to fit together a cookbook. So we took their favorite recipes and we published them, we printed them, we passed out the cookbook door to door. We used that as an opportunity to collect more feedback for our evaluation. And some of the recipes were simple, a lot of vegetarian recipes, but they really, these are items that can be, many of them picked up out of food distribution. And then what we focused on are the things you really can't get through a distribution, save that money to buy the remaining items to create an inexpensive, healthy, but also tasteful recipe. And so in the third quarter, we started grocery store field trips and pop-ups. So this is our team and some of the residents at HEB. Another thing the community health workers did that was absolutely amazing is they worked with Dr. Sharma, Diana, and me, and we applied for a grant from HEB. We were awarded a very generous grant that was $6,000 in gift cards, which we used to take the residents of the grocery store to buy foods, all different kinds of items, even some gardening supplies and plants. But it was very generous and it helped. But the grocery store field trips were wonderful, and we all attended. And a major theme that came out of our research was community integration. So one resident quoted, "The best part of being here is being here with my friends." Another resident told me, "I hadn't ridden in a car in a long time. Being able to go to the grocery store with others was helpful because this is not something I would do by myself." And so I think that the important thing too that we can think about is there are sometimes some mental health issues or maybe some anxiety that's under the food insecurity. So it's not that people aren't trying to help. I mean, everyone is so committed and doing the best they can to help this population, but sometimes it's just a combination of mental health, anxiety, lived experience that makes it to where sometimes there's a reluctance for the residents to leave their rooms, to go to the grocery store. Even if they have the benefits, they might not be going to the grocery store. So I think this project kind of came with the multi-level intervention. We were able to really partner with the residents to get them to kind of get out of their comfort zone, if that makes sense. And then we implemented the community garden, and that was a really great experience. And Diana provided a lot of leadership in it. We decided for this project to really just focus on grow bags and more using like window boxes, things like that, instead of a big garden. We would like to eventually come back in with a bigger garden, but we had a core group of residents who were really engaged in the community garden part, but we didn't want to go in, plant a big garden, and then leave it there for other people to have to take care of. So these are some themes and quotes. Diana, would you like to talk a little bit more about the gardening experience?
Yes, so we were at two of the buildings. We had Temenos 1 and Temenos 2. So this is Temenos 1. They had already these great pots outside of the building where it got a little bit of sun. So for this building, we did just a shared a couple of pots like this where we had herbs and we had different items that are a little bit easier to take care of. And we just planted our transplants there and they just loved, I believe it was in this building, they created a watering group where they, kind of agreed with their co-residents and saying, today I'm going down, or are you going to be here tomorrow and things like that. So they really took ownership of the garden over there. And then in the other building, we had a little bit more space, a little bit more people. So we did grow bags. So each individual got a grow bag and they got to choose again what to plant. So at that point, I believe it was about this time last year. So we had collard seeds, we had kale, we had our cilantro, our parsley, and some rosemary. So again, they took ownership of that space, and it was really nice of them. They called it my babies, and they came down. So they really took good care of them, and it was really lovely to see. And then, of course, teaching them you can actually, pick a little leaf off and eat it and add it to your meals to add flavors. So that was a special component.
So it was wonderful, and we were able to too with the leftover grant money, we purchased additional gardening supplies, grow bags, and seeds, and we donated them to the program. So we feel like that was part of our sustainability, and we definitely want to go back and do more. I mean, our behavioral health grant is still there, so we definitely felt like this was just a first step with the pilot. But we did decide to have a formal graduation, so that was a great event. So we printed, graduation certificates. We had a luncheon. You can see two of our community health workers, Raina and Farah, handing out the certificates of completion. And so it was just a really fun project that really was an honor for at least I can speak for myself, but probably all of us. It was just an honor to be there, and we feel very grateful to Houston Methodist for giving us this pilot funding to have implement a project. And so these are some of the different people that were involved. So PJ, she's in the bigger slide, she was the housing manager who really made this project possible, really she was really our go-between with the residents, also with the housing staff, letting us know about some of the shut-ins that we did, were able to reach out to. When we, this picture of them, when we took the rest of the grant money and bought all the supplies and extra equipment for the residents, she and someone else came over, they made I think 4 or 5 different, brought truckloads of stuff because we had it all delivered to the medical school, and they brought it back to Temenos. And JC, with a therapist, and our lead community health worker, Sarah, and then our residents. So just a little bit more, I know we have a few minutes left, but I just wanted to show a little bit of our data. So we didn't have quite as many follow-ups as we did baseline screening assessments, but as you can see, at our baseline, we surveyed 83 residents, and we found that 64%, so 53 of them fell into the very low food security range, which we reduced to 30 at follow-up. Now, some had dropped out or some declined to participate in the follow-up. We also had some that were, in high food security in the beginning, but we did have really big reductions that we're happy about, but we think we could do more. One of the issues is that during this project, the rules for SNAP changed. So at the beginning of the project, the SNAP benefit amounts were much greater because of COVID. So part of the issue might have been that as the project persisted, there was a cut in SNAP benefit. So even if we were doing a lot of work, there was still more food insecurity than we wanted to see just because of the change in benefits. But it is also a very pernicious problem, I guess you could say. That it's a challenge, and so part of what we want to do is raise awareness for other homeless service providers that this is going to be an ongoing challenge. That we one of our therapists, JC, he always tells me we've been working with this population for a long time, and he says, a lot of people, providers, residents, consumers, they all see housing as the finish line. So I think that's the other thing that we want to think about is it's really in a lot of ways just the beginning. You know, we get somebody housed and it's a wonderful thing to celebrate, but we want to keep them housed. We really want to address their needs and we want to really increase their quality of life. So it's a hard endeavor. So yes, we'd like to see more reductions, but we still feel like we made, you know, some progress. And these are our major themes. So across our needs assessment, the questions that we asked for following the nutrition education, as well as the comment cards that we collected and brief feedback that Clara, one of our managers, and I went door to door when we distributed the cookbooks, so we got additional feedback. So, you know, some of the major themes to be aware of is this, you know, the persistent lack of necessary items. You know, we even may sometimes give people items and then they share their, you know, it's just it's an ongoing process to make sure people have what they need, that we're addressing knowledge gaps. But we do feel like that one of our major accomplishments is that we had a definite increase in positive perceptions of healthy food options, you know, thanks largely to Diana's guidance, as well as we were able through our cooking classes to expand preferences for healthy and easy to prepare foods. So, you know, our goal was, you know, what can we teach you to prepare that's healthy, that you're not, you know, taking your money, going to the convenience store, going and eating fast food, you know, as well as the community integration, you know, walking, you know, going with our residents out into the community, going with them to the grocery store, going with them to the food banks. As Diana mentioned, their ownership of the garden, it's their garden. And then also getting a lot of comments from them that they really felt like regaining cooking skills after homelessness was important for them, as well as having those positive experiences with other residents. So one of our primary outcomes that we want to measure maybe in the next project is social connectedness, because that's going to be a real key to like not only improving their quality of life, but also they're improving their mental health. And then, so our program findings. Preliminary findings suggest the use of the human-centered design methodology for planning and implementing this multi-level community health worker intervention helped to reduce food insecurity. It engaged participants in learning and adopting healthy and safe cooking and eating practices, and it fostered social connectedness and, you know, resident-reported feelings of community among formerly chronically homeless adults and permanent supportive housing. So that's what we found, and these are some additional pictures, you know, gardening, Sarah, our lead community health worker. The bottom picture is our luncheon that we had with the medical students and the residents. And we just want to quickly thank all of our partners. Diana, do you want to talk a little bit about some of the like Buchanan's and
Yes. So for the gardening, we actually applied for Buchanan's. They have a community grant. It was very, very small, but that was what was able to help us buy seeds and buy seedlings so that we could get the gardening going. Of course, Dr. Hamilton mentioned HEB, which is how we were able to do those grocery store field trips. So during the field trips, we actually took them around. I gave them a little My Plate kind of grocery store grocery list so that they could make sure that they got something from each food group. And so through our partnership with HEB, we were able to actually purchase a couple of items from each food group for them. So we taught them that My Plate, and we actually said, this is how you build a meal with that, and here's the groceries for it. So that was really lovely. And then, of course, we had plenty of other partnerships that Dr. Hamilton can talk about.
So as part of our SAMHSA behavioral health treatment grant, one of the ways that we wanted to foster sustainability was by taking the population that we worked with very closely and kind of turning them over to our therapy, our other initiatives. So we, right before the project ended, we our therapists, Raina and JC, and myself and our team, we all did like we had a luncheon and we did an outreach event where we brought everybody together and we talked about having a wellness group. So we decided to use an evidence-based behavioral health curriculum called Seeking Safety, and we invited all the participants from the nutrition program to be in our program. And so many signed up, and then the way we kind of provided some continuity is we had like quite a bit of that HEB grant money left over. So we said, okay, if you come to this wellness group, which is going to focus on your behavioral health, we'll provide a healthy lunch every week. So that's something that we did for like the next 9 months or so, as we provided the lunch, the group, the therapist facilitated, I went often. And so that provided a lot of continuity. And then also second servings, we want to thank them for, they sponsored our 2 grocery store pop-ups. Again, University of Minnesota's Extension, their SNAP Ed training was fabulous, and I invited them, and I'm hoping they're here today, as well as Houston Methodist, who was absolutely wonderful and awarding us the Community Benefits Grant, and Bread Alive, whose overall mission is to reduce food insecurity. So they were the perfect partner for this initiative, and we're still working with them through a new SAMHSA grant. And also to thank all of our team members, besides Diana and me, Sarah Seinfeld, Reina Jose, Vera Hamadan, Dr. Simmons, Calvin Wong, Clara Smith, Eva Thibodeau, Dr. Sharma, Reina Williams, and JC. So that's our presentation. So we have about 14 minutes left that we could open up for questions.
Yes, thank you so much, Dr. Hamilton. That was really exciting. It was such impactful work just to be part of. So it's always great to be able to talk about it. So we did get a couple of questions in. If you have any more questions, please add them to the chat. So I'll just go through what we've got here. We had one question asking if there was pre-post assessment. So we saw the data for food insecurity, and then we had some comment cards. Is there anything else you want to add, Dr. Hamilton, about the pre-post assessments?
So the primarily pre-post was the USDA food security survey, but we also had our needs assessment. So we conducted additional follow-up needs assessment questions to see where we've made improvements, as well as the qualitative data that we collected through the comment cards and the questions. So we didn't have as much as we would like. This was a pilot, and it was primarily service delivery. So I think that is really where we'd like to go with another grant, is to do a more formal study and to collect more data. But we also have data from our SAMHSA grant that we're using to kind of supplement what we collected through this project.
Good. Awesome. Wonderful. And then since we mentioned SAMHSA, we can go to our last question, which was if you could talk about your partnership with SAMHSA and their contributions to this program. So you talked a little bit about that, but anything else that you'd like to add for SAMHSA's contributions?
Oh, absolutely. So when we were originally funded in 2018, we received a 5-year, $2.5 million grant from SAMHSA, and the initiative is called Treatment for Individuals Experiencing Homelessness. And so this is the project that really funded us to do this work with the homeless. And we also were able, because many of the residents enrolled in the nutrition program were also enrolled in our SAMHSA project, we were able to access some SAMHSA funding to kind of also supplement what we were doing within the nutrition project. So they were, the SAMHSA project very much was a part, the funding supported this project. Also the therapists are funded through the SAMHSA grant, and really taking our behavioral health expertise and using it to increase engagement. That was an important part of this.
Okay, wonderful. We had another question. I'm not sure if it was aimed at both of us or me or Dr. Hamilton, but it says, would you be open to partnering with other organizations for referrals to your program?
No, absolutely. So we, in the Houston area, we are taking referrals for behavioral health treatment for people experiencing homelessness, but we also have a community health worker on the team. We have a research assistant. And so we are working with other organizations. We're also open to partnering to apply for additional funding. So absolutely, and y'all can see my email, and we'd love to continue to work with Diana. So this is important to us. We really want to treat the whole person. You know, we're about prevention as well as integrated behavioral health treatment. And we really, our whole goal really was this recognition that we don't want to deliver therapy to people who are hungry. We really want to address all the issues and address all social determinants.
Okay. All right, so we had a couple questions on the games. So the games probably made the information more approachable. Was there any level of food health literacy that was uniquely a gap that you have not seen in other populations? And then I think it's a very similar question. How did you decide on what games to play considering the population's motivation level and age? So with the games, I really just took what they were already doing. So they were already playing bingo. So I thought that was a very easy in terms of just going in and doing a nutrition bingo. So we adapted a board game that we actually already had in our office where you have the bingo cards with the different My Plate food groups, and then there are different food items from each food group. So then we would just say, this item has a lot of vitamin C, and then they would guess the food item and then, fill out their bingo card. So in terms of health literacy, we used very, very simple words. We really just talked about food. So we weren't very advanced at all in terms of, we weren't talking about like, I don't know, vitamin D's, combination with calcium and this and that. No, we were just talking about food because, again, we wanted to make it very approachable and not something that was super academic because, you have to know your audience. So that was kind of the level that we were looking at. There really wasn't a gap. A lot of people, we had one participant who previously had worked at a grocery store, so he recognized a lot of the different fruits and vegetables, and we had photos and things to really make it very easy to see. We had people who had been to a class for their diabetes or for XYZ, so there were varying kind of health literacy levels, but they all kind of helped each other and were able to learn. So we made it very basic, and then the people that knew more, they could just kind of show off a little, and it was really fun for them. And then in terms of age, again, just looking at just the classics. So we did a Jeopardy, and people loved the Jeopardy. We played the sound, the little da da. So they really loved just the nostalgia of the classic games that we've done. So that's kind of how we decided on those. It was really just what I came up with. And then where do we find these games? They're not out anywhere, but I'm happy to share. So whoever asked that question, if you'd like to email me, I'll send the email in the chat. I'll send my email in the chat. Another question that came up was there any assistance provided with signing up for SNAP? Because it's a very large and daunting application.
So there's two ways that we provided assistance. So there is, at the Permanent Supportive Housing program, there is a full-time homeless service agency called Search in Houston. And so they, as part of what they do, they were routinely screening people for SNAP benefits and helping them apply. The issue is that because of the mental health and some of the barriers, that some of the residents had, there were some people that hadn't applied for SNAP or that they were not following through. So we more assisted there. And then we really focused on engagement, and through our needs assessment, identifying everybody that didn't have SNAP. And then, yes, absolutely, we tried to connect them with the on-site case manager to get that SNAP application completed. But if it wasn't happening with Search for whatever reason, we would also provide that assistance with the application because we had our community health workers. So yes, we were providing a lot of assistance.
Great. And then we had a couple questions on demographics. So as far as demographics, how many among the individuals experiencing homelessness who were residents are also individuals with physical disabilities? Do you have an idea of that?
And so I would say, so we looked at it more with chronic health issues. So when I had the demographics given to me so I could apply for the grant, I would say about 70% have a serious mental illness, probably 50 or 60% have some kind of a chronic illness or a physical impairment that could be, it may or may not be a mobility issue. But definitely it's an aging population, mostly with multiple morbidities. And within our resident population, while we were implementing the project, there were several individuals who had cancer. There were ongoing health challenges that we also tried to support the residents in. Sometimes our community health workers, even if they weren't the primary community health workers and case managers, because that was search. If there were residents that were really involved in our program, then our community health workers would go with them to medical appointments or to help talk with them more about the management of their chronic illnesses. But again, 72, I think that was the number that we presented earlier, had mobility impairments to the extent that they couldn't walk less than a mile to the food distribution. So it's quite a few had these impairments that were limiting their mobilities. Mm-hmm. And there's elevators in the building, so that's important to think about.
Yeah, and then from my experience, we did have some people in a wheelchair, so when we did the cooking classes, they just rolled up and they were still able to cook, which was great. And then we also, during the games, that was another thing that I was going to mention, we again made it very, very simple, very small words, and then also had pictures. We did have at least one, if not more, residents who had impaired vision due to diabetes, I believe. So, you know, putting up the pictures very large and then even describing, saying, here we have a tub of yogurt compared to a tub of, sour cream. So we made it the games and the program as accessible as possible in that. Another quick demographic question was the age group, or I guess the age range of the residents, if you happen to remember that.
Mm-hmm. So the residents, the range is 18 to I think 72, but the average, if you look at the mean age, it's over, it's late 40s, early 50s. So the majority, I would say, are in their 40s and 50s. Does that sound correct? And that's generally the homeless population in Houston.
Yeah.
The majority are over the age of 50s.
All right, we have a couple of more minutes and a couple more questions. So one question was on Amazon Fresh. Were participants able to navigate Amazon Fresh easily once they signed up? Love this idea.
So that was something the community health workers were very involved with. So that is something that was part of their one-on-one home apartment visits, is they would identify the residents who wanted to sign up for Amazon Fresh, and they would assist with the applications and then help them navigate the process until the deliveries were being, were really set up and it was going well. So,
yeah. Yes, and from my experience, they were, as long as they were able to, manage their phone. There are some people who are not very phone savvy, but the people who are phone savvy and could, pick out their foods, and they already knew what they liked, they knew what they wanted to order. So I did help with a couple of those, and it seemed like they felt pretty good about Amazon Fresh. So it's a great option. I hadn't thought of it. So it is something to consider because they do take SNAP and they do deliver, which is great.
Yeah, and I just want to make a couple plugs. So we started with our original grant with Temenos with cell phones for the homeless or formerly homeless. And so we had a grant in collaboration with the American Psychiatric Association and a cell phone for the homeless organization on the West Coast. So we have worked closely with Temenos to make sure that every resident has a phone, because that's really a key piece. Now we're learning a lot more about the Lifeline phones or Assurance phones, because if a resident has SNAP benefits, then they're eligible for a free phone. So I think that's a very good point to bring up the Amazon Fresh, because we also want to make sure that everyone has is connected digitally to be able to access the deliveries.
Great. Okay, we have one last minute. Guess we can take one last question. So did we include any quality of life questions, or is that something you would include in the future?
That's a great question. So we actually used the SF-36 in our SAMHSA grants. We've collected it on some residents, but definitely it's something we should include in the future as a formal assessment. And there is one quality of life question too in the SAMHSA tool that we have to administer and take in 6 months. But yes, we would definitely want to assess it for every resident in the nutrition program.
Wonderful. All right, so we are just about out of time. Thank you to everyone. Thank you for Dr. Hamilton for being here and for presenting on this work. It was such powerful and wonderful work. So I loved being a part of it. Thank you all for attending today's webinar. The recording, slides, and resources mentioned will be posted on our website. We appreciate you being here, and we will see you for our next Dell Center webinar, 1 p.m. Tuesday, April 2nd, Tucker's Law and Best Practices in Youth Substance Misuse Prevention, and then for Best Practices in Youth Nutrition Education at 12 p.m. on Tuesday, April 16th. So have a wonderful rest of your day, Thursday, close enough to weekend so we can say happy weekend. And thank you for being here.